So there are different criteria for selective His captures. So this is how a selective His bundle pacing looks. The first thing is the QRS gets narrowed. So suppose the QRS is in a left bundle branch block is 195. Here you might get a His bundle correction. Suppose it's corrects to 125. So basically the QRS gets narrowed. That's the first thing that you can note. So in a His bundle pacing, you try to get to the closest possible to the distal His bundle. So the HV interval should be the shortest, to try to get to the shortest HV interval when you place the His bundle lead. This is one example of a His bundle pacing, so own rhythm with a complete R block. And this is a myocardial. In a His bundle pacing, if you find a pseudo delta wave, you are not right on the His bundle. There should be a flat baseline between the P wave and the QRS. If there is a sudden takeoff without a delta wave, that is very accurate to be on the conduction system. And you can know that it's a selective His bundle capture. So this baseline is indicative of, isoelectric baseline is indicative of His bundle capture, selective capture. There are different mechanisms by which the left bundle branch block is reversed by His bundle pacing. And while in left bundle pacing, which is technically very easier to do, you don't need an EP system. Generally in an RIU view, you target your catheter beneath the tricuspid valve, take it beneath to the apex or to the RVOT, withdraw back and turn it clockwise enough so that it faces on to you. And when you start screwing, it should be around 12 to 1 o'clock view in the RIO 30 view and about to 2 to 3 o'clock position in the LAO 40 view. So this is the position of where you screw the left bundle lead and you screw from your patient end and outside end and it goes and you can know in LA view that it has roughly crossed the septum. The endpoints I'll come to. Sometimes it is good to know an echo thickness so that you will know how much to turn. So because the difference between the length of this tip of the lead to the end of the anode is around 10.2 centimeters. So you can know from that you can know how much to screw to the septum. The only thing is that the bipole should be on the septum. If you have a thin septum, still you can place the bipole. Only the proximal part of the septum need to touch the anode need to touch the septum to have a bipolar pacing. And this is in a left bundle pacing, what you get is an RBBB morphology in V1. You can see that there is an RBB morphology in V1. This is again a complete heart block paced with left bundle pacing, very proximal left bundle pacing, the native QRS. And after left bundle pacing, you get a very narrow QRS RBB morphology in V1 and relatively narrow QRS. You can have an anterior fascicular pacing where you get an RS pattern in 2-3 AVF or a posterior fascicular pacing where you get a QR pattern in 2-3 and AVF. This is another case where a congenital CHB, high grade AV block in an 8-year-old boy. This is pre and post pacing. You can see that the QRS is extremely narrow and the child is doing well. The growth is well. The advantage of pediatric population having conduction system pacing is that they may not have the growth deficit due to VVI pacing. So they may grow well. That's the advantage. And they will not have a heart failure, especially in other congenital heart disease where heart failure is an associate thing along with the conduction system disturbance. So it's one of the applications elderly at the extremes of age, young age and elderly. And LOT is a concept where you put a CRT and additionally you put a left bundle pacing and connect it to the pace sense port of the CRT. So you have 4 wires. The sensing happens from the left bundle pacing catheter and additionally you have a conventional epicardial coronary sinus lead. So you are basically truly synchronizing left ventricle from either side of left ventricle, from the septal side and from the epicardial side. While in the usual CRT, the actual bisynchronization is happening in a different way from epicardium and RV on another axis. So it's not a true synchronization. So here, when you pace at the base, it's a true synchronization on either side of LV, and you can control the AV synchrony better and VV synchrony better, probably with a LOT CRT. That's the concept. So there are clinical studies. We have been a part of these studies initial group, and we are still following up with imaging on where these can be paced in different areas like LV septal pacing, selective left bundle pacing or non-selective left bundle pacing. So this is a recent review in the JAC, which is a state-of-art paper involving the stalwarts in this area. And basically, you can have a his bundle pacing, left bundle branch pacing, or now it is called as a left bundle branch area pacing, because you don't need to be exactly on the left bundle branch selectively. You can have a non-selective one, or even a left septal area pacing, where the QRS need not be exactly very narrow. You can have a slight myocardial capture, so that you are very near the septal conduction system, but not exactly on the conduction system.